Hello doctors, welcome back to Pirates of Medicine. So in today's video, we are going to continue with the anatomy based questions from where we left in the last video. Before we start, I would respectfully urge you to consider subscribing to the channel and sharing the videos with your friends so that it is beneficial for both your friends and the channel itself. So without any further delay, let's begin with the base. Okay, so the 11th question is that the alveolar ventilation of a patient is 5 liter per minute. The breath frequency is given as 10 per minute and the tidal volume is 700 milliliter. So they are asking that what is the patient's dead space ventilation. To understand this, we need to know some respiratory volumes. So the first important respiratory volumes is the tidal volume. Tidal volume is nothing but it's just the amount of air that can be normally inhaled or exhaled during one respiratory cycle. So without any forceful respiration, the volume of air that can be inhaled or exhaled during one respiratory cycle, it is the tidal volume. So normally in adults the volume is around 300 to 500 milliliter. Now the inspiratory reserve volume, it is the amount of air that can be forcefully inhaled after a normal tidal volume. So after a forceful respiration or forceful inhalation specifically, the total volume in the lung at that time is called as inspiratory reserve volume. So the normal adult volume for this inspiratory reserve volume is 1900 to 3300 milliliter. Expiratory reserve volume is nothing but the volume of air that can be exhaled forcibly after exhalation of a normal tidal volume. So in adults, the normal value of this volume is 700 to 1200 milliliter. Then we have a concept of residual volume. It is the amount of air remaining in the lungs even after maximal exhalation. So in normal adults, it is averaged at 1200 milliliter. So this volume is the amount of air that stays in the lung even after forceful exhalation. Then we have the minute ventilation. It is the total volume of gas entering or leaving the lung per minute. So it is just the tidal volume multiplied by the respiratory rate. So every minute, the amount of air entering or leaving is known as minute ventilation. Then we have a concept of alveolar ventilation. It is the amount of gas per unit of time that reaches the alveoli and becomes involved in the gas exchange. Alveoli, we know, are the sites of diffusion in the lungs, the sites where gas exchange occurs. So alveolar ventilation is the amount of gas that reaches the alveoli and actually becomes involved in the gas exchange. So we know that dead space ventilation is the amount of air that does not get involved in the gas exchange. So alveolar ventilation is just the minute ventilation subtracted by the dead space ventilation. I think that clears the topic. So let's go back to the question. So in the question they gave the tidal volume to be around 700 milliliter. The respiratory rate was around 10 per minute. The alveolar ventilation they specified was 5 liters, which we can say as 5000 milliliter. So according to the formula, we need to first find the minute ventilation, because in the question they asked about the dead space ventilation. So minute ventilation can be found out as tidal volume multiplied by the respiratory rate. Using the formula, it comes out to be 7 liter or 7000 milliliter per minute. So alveolar ventilation is equal to minus minute ventilation subtracted by dead space ventilation. So if we put the values here, like alveolar ventilation is given in the question itself, minute ventilation we found out, and we need to find the dead space ventilation. So dead space ventilation comes out to be 2000 milliliter per minute or 2 liter per minute. So that gives the answer to the question. So I hope it is clear. So let's go to the next one. So during investigation of a patient, it was found that formation in the white substance of the cerebral hemisphere with the location in the knee and the frontal part of the posterior cross of the internal capsule. Fibers of what conductive tract were disrupted? So to understand this, let's take a look at the internal capsule itself. So the internal capsule is an extensive band of white fibers that connects the cerebral cortex to the subcortical structures, which we know are corpus striatum, thalamus, and the brain stem. So you can think of the internal capsule as a conduit. So it is like a canal that gives a way to the ascending and descending fibers from the cerebral cortex and to the cerebral cortex. So it is made up of an anterior limb, a posterior limb, and a horn-like formation, which in Latin is called as a genu. So there are some tracts that pass through the different limbs and the genu of the internal capsule. So the frontopontine and the thalamocortical fibers, they transfer through the anterior limb. You can see this is the anterior thalamic radiation and the frontopontine and the corticofugal fibers. Now the genu gives some part of the way to the corticobulbar tracts, which we also know as corticonuclear tracts. So genu, a part of the horn of the internal capsule, gives way to the corticobulbar tracts. The rest of the corticobulbar tracts and the corticospinal and some of the thalamocortical fibers, they pass through the posterior limb of the internal capsule. So guys, corticobulbar tract and the corticospinal tract together are known as pyramidal tracts because they decussate at the pyramids of the medulla. So this is why they are known as pyramidal tracts. So according to the question here, the fibers are located in the knee as well as frontal part of the posterior crus of internal capsule. So like I told you, those fibers are known as pyramidal tracts, the corticobulbar and the corticospinal. So that is why these tracts will be disrupted, because the formation is in the knee and the frontal part of posterior arm or posterior limb of the internal capsule, which is the corticobulbar tracts and the corticospinal tracts. So I think this clears this question as well. So let's go to the next one. So this question is a biochemistry question that we all have learned in our 12th grades. So only one factor that can influence the charge of amino acid radicals in an active center of enzyme. They're asking what factor. The answer is pH medium. I'll tell you why. So amino acid has a unique ability to form Zitter ions. Zitter ions are what? Zitter ions and ions which have both the positive and the negative charge at the same time. So imagine ion which has positive and negative charge which at the same time. So if an acid is added to a solution, it just means that hydrogen ions are added to the solution. So the hydrogen ions, they get attached to the negative part of the Zitter ion, and thus this Zitter ion becomes positively charged. And imagine if a base is added, so hydrogen ions are removed from the OH ions are added when base is added. So hydrogen ion is removed from the base part of the basic part of the positive ion part of the amino acid, which is NH3 positive, and it gives NH2 positive, and the whole Zitter ion becomes negatively charged. So what happens, why this is important clinically, it is because changes in pH can induce these changes, and these changes in the ions or the radicals of the amino acids make conformational changes in the amino acids, and thus the enzymatic capacity of the sum of the enzymes is disturbed. So this is how the pH medium influences certain enzymes, or specifically the amino acid parts of those enzymes. So let's go to the next one. So succinate dehydrogenase catalyzes the dehydrogenation of succinate. So this is a question from the Krebs cycle. So malonic acid is used to interrupt this action. So they are asking which inhibition occurs. So they have given certain types of inhibition. First we have competitive. We'll talk about competitive. Let's understand the other ones. Allosteric inhibition is that there is a concept called as allosteric site of the enzyme. So according to this concept, there are two sites in an enzyme, one which catches the substrate and makes the product, and there is another site which is known as the allosteric site. So certain compound which is a allosteric inhibitor or allosteric stimulator, it gets attached to that part of the enzyme and makes the enzyme change conformationally and induces some changes in that enzyme. So this is the type of allosteric inhibition given in this MCQ. So then we have non-competitive. Non-competitive is, you can see that it has nothing to do with competition. A limited proteolysis can be inhibitory or can be it can cause activation, like in proteinases like pepsin or trypsin. These enzymes, they occur as pro enzymes first. So then there is a proteolytic activity in the stomach and the intestine which activates this enzyme. So this is how limited proteolysis activates the enzyme. In a similar way, limited proteolysis can also inhibit the enzyme. Dephosphorylation is nothing but removal of the phosphate group. It can also cause some changes in the enzyme which may either activate it or may either inactivate it, depending on the enzyme we are talking about. So let's talk about competitive inhibition and what is happening in this case. So competitive inhibition is like interruption of a chemical pathway owing to one chemical substance inhibiting the effect of another by competing with it for the binding site. So malonate is the competitive inhibitor of the enzyme succinate dehydrogenase. So what happens is that an enzyme works to bind the substrate and changing it into a product. So, but there are certain substances which can fight and compete with the substrate for the enzyme. Like here, succinic acid is the substrate which is meant to be with succinic dehydrogenase. But this guy, malonic acid, comes and says that no, I want succinic dehydrogenase as well. So we're gonna fight. And in this competition, what happens is that the formation of product or the enzymic activity of this enzyme is reduced. So this is competitive inhibition. That's the whole topic. So they asked which type of inhibition does malonic acid indulge in. So it is competitive inhibition of the succinate dehydrogenase enzyme. So let's go to the next one. Next question is that the gluconeogenesis is activated in the liver after intensive physical training. So what substance is utilized in gluconeogenesis, first of all, in this case? So gluconeogenesis is the formation of glucose from other substances in our body. So these substrate for glucose production in the body can be lactate, can be pyruvate, can be acetyl coenzyme A, can be fatty acids, they can even be amino acids. And so gluconeogenesis normally occurs in conditions of starvation or sometimes when there is an emergency need of glucose somehow. So, and glycogen or other sources are not available. So this is how gluconeogenesis occurs from these substrate. So they are saying that the patient has undergone intensive physical training. So in intensive physical training, first of all, what happens is that in muscles there is a lactate formation because of anaerobic respiration. This lactate transfers to the liver, which is the site of gluconeogenesis, and glucose is formed from it, and the glucose is given back to the blood and it goes to the other parts of the body and to the muscles as well. So in physical training there is an extensive formation of lactate. So this lactate will be used for formation of glucose because it cannot be stored in the body as it causes acidosis, and it also causes cramps in the muscles. So it needs to be detoxified, in which there's no better place than the liver to do it. So other than that, let's talk about the gluconeogenic precursors. So gluconeogenic precursors are the molecules that can be used to produce glucose in the body. So I told you some of these, like one, there is glycerol, there is lactate, there is alpha keto acids, and all these alpha keto acids are obtained from the metabolism of glucogenic amino acids. Glucogenic amino acids are the amino acids which give glucose in the end of their metabolism, and there are also ketogenic amino acids which give ketone bodies in the end of their metabolism. So only two amino acids except the leucine and lysine are glucogenic. All amino acids except these two are glucogenic. So glucose can be produced from all amino acids except all 20 except leucine and lysine. Then we have lactate. So lactate from the anaerobic glycolysis is released and it goes and by exercising skeletal muscle, which was given in the question, and by the cells that lack mitochondria such as RBC, because RBC is also site of anaerobic respiration. So in the Cori cycle, this lactate is taken up by the liver and oxidized to pyruvate, which is converted to glucose in gluconeogenesis, which is released back to circulation. So in the question, there was intensive physical training, maybe gym guy, so lactic acid was formed and it goes to the liver, and via the Cori cycle it is converted into glucose. Okay, so a patient, 16th question for this base is that the patient with a stab wound on the interior stomach wall is in surgical care. So what formation of the abdominal cavity did the stomach contents get into? So bursas, guys. Bursas is a pouching of a peritoneum or a body structure in which fluid can get accumulated in abnormal conditions. So there are certain bursas located in the peritoneum. We'll talk about a few of them in this case. So what you need to notice is that the stab wound is in the anterior stomach wall. Correct? So let's see. So this is the stomach and this is the anterior stomach wall. And in this view, transverse view, this is the stomach and this is the anterior stomach wall. So in this blue part, this blue underlined portion is actually the less, it is known as the omental bursa, because the omentum is located here, and this part in front of the stomach, this bursa in the stomach, front of the stomach, is known as pregastric or anti-gastric bursa. So again in this red portion, you can see this part is the anti-gastric bursa or the pregastric bursa, and this blue portion you can see as omental bursa. So if as you can see, the anti-gastric bursa is continue with the other bursas or the other part of the peritoneum, so it is not actually a differentiated structure, but here omental bursa can be seen differentiated from the rest of the peritoneum. So if there is a stab wound in the anterior wall of the stomach, the fluid will get accumulated in the antegastrial bursa, and if there is a wound in the or perforation in the omental wall or the posterior wall of the stomach, the fluid will get accumulated in the omental bursa. So antegastrial bursa and omental bursa. Correct. Hepatic bursa is a small bursa located in the liver, near the liver, under the liver. So that is not the case over here. Correct. So let's go to the next one. Okay, so a patient had been taking glucocorticoids for a long time. Now the patient, when the preparation was withdrawn, the patient developed the symptoms of disease aggravation, decreased blood pressure and weakness. So what is the reason of this condition? So you know that glucocorticoids are actually synthesized by the cortex or the cortex part of the adrenal gland. So if you are taking glucocorticoids as a medicine, so what will happen is that the body gets acclimatized to external supply of glucocorticoids, and the synthesis of glucocorticoids in the adrenal gland itself is discontinued. So if you suddenly withdraw glucocorticoids that had been taken for a long time, what happens is that there occurs a condition called as withdrawal or abstinence. So in withdrawal, when the sudden supply of glucocorticoids which is needed for normal functioning is withdrawal, and the adrenal gland is not able to adapt and synthesize the substances or the glucocorticoids or the other substances back again, so there is an appearance of adrenal insufficiency, that the adrenal gland is not able to go back to the normal functioning because of sudden withdrawal of the glucocorticoid preparations. So this is what is happening in this patient now. This patient has habituation of the drug. He is undergoing withdrawal symptoms, and normally when you are taking glucocorticoid therapy for a long time, you need to slowly decrease the doses so that the patient's body or the patient's adrenal gland are able to get acclimatized to the decreasing dose of the glucocorticoids. So that is happening, there is an appearance of adrenal insufficiency. So that is why the answer here is appearance of adrenal insufficiency. Okay, so the next question is that the patient has tissue ischemia below the knee joint accompanied by intermittent claudication. So what artery occlusion should be suspected? So guys, for understanding this, you need to have a basic knowledge of the arteries of the knee. So let's see, arteries of the knee or the lower limbs or the thigh. So let's see what's happening here. So you can see this is the thigh, this is the knee joint, and this is the lower part of the lower limb. So there is the femoral artery coming from the top. The femoral artery is the main artery of the thigh. The femoral artery, when it comes to the knee, it continues as the popliteal artery. So in the question they said that there is a ischemia below the knee. So all this part is deficient of blood. So as you can see, the best part to cause ischemia should be to stop the blood supply over here. Correct? So, or over here, so that the blood supply below the knee joint is disrupted. So what happens is that if the popliteal artery, which is the main artery of the knee, is disrupted, then the blood supply to the lower limb will be disrupted, which is happening here. There is ischemia below the knee joint. So if you stop the artery over here, or a thrombus stops the artery's blood supply over here, then blood won't go down to the limb. There won't be any blood in the posterior tibial artery or the fibular artery or the anterior tibial artery, and that is why it will cause ischemia symptoms. I think that clears this. So let's go to the next one. Okay, so the 19th question is a question of biochemistry or clinical biochemistry, if I say. So a patient who suffers from congenital erythropoietic porphyria has skin photosensitivity. So the accumulation of what compound of the skin in the skin has caused it? So porphyrias are the disorders of heme synthesis. So we need to understand heme synthesis, the heme part of the hemoglobin, to understand porphyrias. So this is a simple diagram or simple representation of the heme synthesis. So the substances, the whole heme synthesis occurs in the mitochondria and the cytosols, some part in the mitochondria and some part in the cytosol. So in the mitochondria of the red blood, in the mitochondria of the bone marrow, what happens is that bone marrow cells, what happens is that succinyl coenzyme A and glycine are the two substrates which combine to form aminolevulinic acid with the help of enzyme ALA synthase. Now this enzyme goes a certain cycle to form some intermediate products to finally form heme. So what happens after aminolevulinic acid formation? An enzyme called as ALA dehydratase forms porphobilinogen PBG. Then this porphobilinogen is converted into uroporphyrogen 1 by uroporphyrogen 1 synthase. Then this is converted into uroporphyrogen 3 by uroporphyrogen 3 synthase. And then this uroporphyrogen 3 is converted into corpoporphyrogen 3 by uroporphyrogen decarboxylase. And this goes to the protoporphyrogen, which is converted into protophyrin 9, which finally converts into heme by this enzyme which adds iron to the protophyrin. This enzyme is known as ferrochelatase. So this is the basic mechanism that undergoes during formation of heme. Now if these enzymes of the heme synthesis are impaired by either congenitally or hereditary factors, or they are deficient due to some cause, there occur some disorders known as porphyrias. So before porphyrias, let's talk about the two enzymes which are very sensitive to lead poisoning. Lead poisoning, when there is an increased quantity of lead in the body, what happens is that these two enzymes, ALA dehydratase and ferrochelatase, they get disturbed and they stop working. So what they actually do will be stopped, and porphobilinogen or heme won't be formed, and there would be an increased quantity of aminolevulinic acid in the body, and also succinyl coenzyme A and glycine levels will be increased. They also occur various symptoms which are similar to porphyrias, and so that's what happened in lead poisoning. Then we have acute intermittent porphyria. Acute intermittent porphyria is by deficiency of uroporphinogen 1 synthase. So if this enzyme is deficient, uroporphinogen 1 will not be synthesized, and there would be increase in amount of porphobilinogen in the body. Remember, the substance that will be increased is always the substrate, and there will be deficiency of the product, and the enzyme deficient is responsible for the porphyria type. So HMB synthase deficiency causes acute intermittent porphyria, in which porphobilinogen is increased in the body and there is absence of uroporphinogen 1. Similarly, then there is congenital erythropoietic porphyria, which is due to deficiency of uroporphinogen 3 synthase. There is increase of uroporphinogen 1 in the body, and this product uroporphinogen 3 is not formed. Then we have porphyria cutanea tarda, which is due to absence of uroporphinogen decarboxylase. There will be increase of uroporphinogen 3 and absence of corpoporphinogen 3. So this is basically the three main types of porphyria that you need to know now. In porphyrias there are symptoms like abdominal pain, or vomiting, and most important symptom is red urine. So there is excretion of red urine in the body, and also there is a symptom of photosensitivity. So these symptoms are the common symptoms of various porphyria, and in cutanea tarda there are some skin symptoms as well. So these are what you need to remember are the enzymes of these porphyrias and what substance will be accumulated in the blood. So in the question there was congenital erythropoietic porphyria. So they asked which substance accumulation causes it. So if there is congenital erythropoietic porphyria, uroporphinogen synthase will not work, and there will be an accumulation of uroporphinogen 1. So that's the answer. Okay, so 20th question, that a patient has malignization of the thoracic part of esophagus. So they're asking what lymphatic nodes are regional for this organ. So you all know that lymphatic nodes are located all over the body. Some are located near certain parts, like towards the top of the lung, the apex of the lung. There are some lymph nodes in the armpit region, which are the axillary lymph nodes, and there are some lymph nodes in the parasternal region. So similarly, they're talking about malignization of the thoracic part of the esophagus. So we need to find out which lymph nodes are located in the thoracic, near the thoracic part of the esophagus. So annulus lymphatic cardiae, a cardiac lymphatic ring, which is a chain of lymph nodes around the cardiac opening of the stomach. You know that the esophagus, when it descends, it gets connected with the cardiac part of this is the part of esophagus, cardiac part of the stomach. So there are some glands which are known as pericardial glands, or pericardial lymph nodes, which are located around the cardiac part of the stomach, which are closest to the thoracic part of the esophagus. So the first lymph nodes that may get malignant cells is the pericardial or the annulus lymphaticus cardiae. So guys, we are done with the topic with the 10 new questions of anatomy base. We're going to do the next few videos quickly so that you are able to cover anatomy as soon as you can. So please stay tuned and please consider subscribing to the channel if you found this video helpful. Please, it would be very helpful so that the channel can reach other students as well. Consider sharing, and if you have any suggestions, just drop down a comment in the comments so that we can know what the subscribers or the viewers want. And that's all. So that's the video for today. It's been nice. See you in the next one.